Okay, good morning, gentlemen, ladies and gentlemen, those who are with us virtually. We'll start session number 6, titled Broken Wires and Catheters. I'd like to invite my panelists, Dr. Fawaz Al-Mtairi, Dr. Umar also, and Dr. Ahmed Qasim. Can you come, please? Dr. Hussein Hishmet is not coming, so if you can sit with us, we really appreciate that. The first session of broken wire catheter, we have the scientific lecture on the broken wire and catheter. I would like to welcome Dr. Lorenzo Azzolini. He, from United States, is Director of Complex Coronary Interventions and Associate Professor of Medicine at Virginia Commonwealth University. And this is a recorded session. He will be talking about how to deal with embolized equipment.
VCU in Richmond, Virginia, United States. Today we're going to talk about how to deal with embolized equipment in the coronary arteries. So most of my talk and the principle outlined here can be found in the excellent manual Percutaneous Coronary Intervention by Manos Brilakis. Chapter 27 deals with equipment loss and entrapment. So what can be embolized or trapped in the coronary arteries? Basically, anything that goes in can get stuck and rupture and then embolize. So stents, guidewires, balloon, microcatheter, arthrectomy devices, and imaging catheters. Let's review one by one these categories. So stents. So how can stent get lost in the coronary arteries? So one of the causes for sure, tortuosity and calcification, and importantly, poor vessel preparation before attempting stent delivery. And of course, in this context, direct stenting can lead to devastating consequences. Also, if resistance is encountered and we forcefully withdraw the stent inside a guide catheter, or even worse, inside a guide catheter extension, the stent can get dislodged at the junction with the guide catheter extension, and of course, stent advancement through a previously deployed stent. So this is the algorithm from Manos Brilakis' book on how to deal with stent loss. So the long story short is that if the stent is still on its wire and in a location where we can deploy it, so for example, a 2-fine stent in a distal LAD, we should just deploy it. We advance a balloon size adequately with the artery and we inflate it and deploy the stent. If the stent is not on a location where we can deploy it, or for example, a 2-fine stent in the left main, there is a size discrepancy, we should try to either retrieve it or crush it. So if the wire position through the stent is maintained, we can try all these techniques here, like the small balloon technique. We advance a small balloon inside the stent, inflate it and drag the stent back. We can snare it. We can advance and twirl several guide wires around the embolized stent, and in extreme cases, even consider surgery. Or if we do not have a wire control of the stent, we can just crush it. So this is a case of a mid-LAD CTO that was crossed antegridally with no issue. The vessel was prepped, but at some point, the operator felt difficulty advancing a 30/33 stent into the proximal LAD. The decision was made to retrieve the stent to further predilate the vessel, but unfortunately, the stent was lost. You can see the balloon is inside the guide catheter, and the stent is severely deformed because you can see a higher metal density here than here. So the stent, we had wire control through the stent, but the problem was that the stent was deformed and in front of the circumflex and diagonal ostium, so it could not be deployed there. So we decided to crash it. We advanced a second guide. It was a CTO, so we already had a second axis. We rewired the vessel with a second wire for the second guide and advanced adequately sized NC balloon onto the second wire to crash the stent. In this case, we perform a kissing balloon inflation to crash the stent because we wanted to avoid that the stent was dislodged and occlude during this crushing maneuver the diagonal ostium. Then we proceed with further stenting also on the left main that requires stenting, and this is the final result. You can see here this orange brown area is where the stent is crushed. You can see higher metal density, and interestingly on on OCT you can see that the metal is crushed and excluded by the newer stent. Our 5-month angiographic follow-up, you can see still a perfect result, very nice endothelialization here on OCT. And so dual antiplatelet therapy could be discontinued just 1 month later. And you can see a 3D volume rendering with higher metal density where the stent crush happened. What about guide wires? So guide wires can be entrapped for a variety of reasons. So the most common is jailing of the guide wire during bifurcation stenting. In CTO PCI, if we perform very aggressive knuckling, we can deform the wire and get it stuck in the calcium. We can also have this problem if we pull a wire back and the wire has a loop at its tip and then it gets stuck in a proximal stent. In case of severe lesion calcification, or in more rare cases where we stand over a body wire and there is a filter embolic protection device in an SVG PCI and we jail the wire with the filter. What about wire fracture? So this can be caused of due to aggressive pulling on entrapped guide wire, of course, due to guide wire over rotation or arthrectomy over a kinked guide wire. To deal with entrapment, first thing is do not pull hard because we can break it. And if we break it, then there will be many times there will be filaments that are not visible fluoroscopically. So we should advance a microcatheter over the entrapped wire to exert a localized traction while at the same time protecting the proximal coronary artery from cheese cutting effect. We can do parallel wiring with a second wire and balloon over the second wire to release this trapped wire, and in extreme cases even perform laser to dislodge it from the trapped side. In case of fracture, we can try snaring. We can just bury it with a stent inside the coronary artery, but we have to be mindful. We have to look at the fragment that was retrieved more proximally and see if there is a net cut or if there is like uncoiling of the wire, because in this latter case, this strategy will not be enough, and this will lead to thrombosis of this fragment. If it's a net cut in the wire and we are in distal vessel, we can even just abandon it just like that without doing anything. Or in extreme cases, especially if there is a lot of filament hanging on in the aorta, we should proceed with surgery for removal. So this is a case of an RCA CTO with severe calcification. The lesion was wired antegrade. As you can see here, we are able to reach the true lumen, but then we have trouble advancing the microcatheter. We perform balloon dilatation, we change microcatheter, we use a guide catheter extension, nothing works. We perform laser, but the laser cannot get to the most calcified area, which is just right here at the curve. So we try to advance at this point a new wire, a rotawire for rotablator, but the wire that crossed the occlusion, a Gaia third, could not be retrieved. And you can see there is a knot here. I will stop this for a second. There is a knot right here at the wire, at the calcified location. So with another microcatheter, we rewire the occlusion to own the distal vessel, and we can clearly see there is now a knot on this location. So we advance a fine cross over the knotted Gaia third, try to pull it out, but it does not work. So what we come up with is that on the second wire that crossed the CTO, we advance a tool, a small balloon, and balloon angioplasty this area to release the trapped guide wire from the lesion. And then we can actually pull out the entrapped Gaia third through a microcatheter fine cross and the guide catheter extension. And this is how it looks. You can see it was just trapped at the most calcified spot of the CTO. And then we finished the case with arthrectomy with a good result. Another case is a proximal to mid LAD lesion, intermediate lesion here, calcified, a bit tortuous. So we interrogate it with RFR, which is positive. We prepare for PCI, but then the RFR wire breaks in this segment here, just at the junction between the radiopaque and radiotransparent portion of the wire. So we try to perform balloon angioplasty, and upon retrieval of the balloon, we try to drag the balloon back to drag the fragment into the guide. It does not work. So we try with a tool, microsnare, and we are partially successful in pulling this back a bit, as you can see here. Then we are here in the left main. We could potentially stent it, but what we decide to do, instead of trapping the wire behind the stent, we give another shot with a bigger snare, a 4-0 microsnare. We are actually able to capture it and pull it, excuse me, and pull everything out. As you can see here, we are able to pull everything out and finish the case. As you can see here, how badly damaged the wire was. There was about to be another fracture in this area here, in the mid segment of the RFR wire, and the wire was clearly fractured at the pressure sensor location, and there was no thread protruding, so it was a safe retrieval in this case. What about balloons? Balloons can be entrapped after rupture because they fail to deflate, because they interact with previously placed stents, and they can fracture because of kinking of the guide catheter, of the balloon catheter shaft, especially if we push a lot and there is resistance, then we manipulate that area, we can fracture it. So treatment of balloon entrapment, we should inflate a second balloon inside the guide catheter at the very tip of the guide catheter and pull everything out as a unit. In this way, we can forcefully remove the trapped balloon, but this also has a risk of, creating hemodynamic strain of the patient and damage the coronary arteries. Second technique can be cut the balloon shaft and advance over the remnant, a guide catheter extension to exert localized traction and then pull or use a snare. In case of balloon fracture, if the fracture occurs inside the guide, we can do the same thing, inflate a second balloon inside the guide catheter and pull everything out as a unit, or snare. This is particularly required in case the fracture of the shaft is not inside the guide catheter, whereas inside the coronary. In case the balloon cannot be deflated, the first attempt should be at deflating the balloon with another inflator filled with saline, which is less viscous than contrast. If this does not work, we should try to burst it with a high tip load wire, ideally delivered with an over-the-wire balloon, because the over-the-wire balloon centers the stiff wire inside the artery, and so we have a lower risk of perforating a vessel. Or we can achieve the same thing by delivering the wire with a guide catheter extension. So this is a case of a long distal in-stent RCA CTO that was cross-antegratally, and we were almost done. We decided to do, after cutting balloon, drug-eluting balloon, and 2DS, and we tried to postulate the stent even further with a 4-0 balloon. But as you can see here, we probably pulled the balloon back too early after partial deflation, and then it gets jammed in the coronary, in the guide catheter. Fortunately, it can be pulled out from the coronary artery. We try to burst it, does not work, very resistant NC balloon. Then we try to puncture it with the back end of a guide wire, and even with a confianza, and it does not work. Then we try to pull everything out as a unit, but the balloon remains trapped at the sheath side. And so at this point, we try to even pull out the sheath, but then the balloon remains trapped at the arteriotomy side. So what we do is to obtain contralateral access, and with a big snare, we just snare this fragment, and we snare it inside the sheath. And this is what happens when we pull it out. It was a very clear fracture here at the junction between the shaft and the actual balloon component. So should wait until complete balloon deflation with large NC balloons. What about microcatheters? Microcatheters can be damaged and entrapped due to advancing through calcified and tortuous lesion. And we can also interlock two microcatheters on an externalized wire if we advance them too close to one another. In case of when does fracture happen? In case of aggressive manipulation, especially of softer tip microcatheters such as the caravel through calcified lesion, or over-rotating a microcatheter. Management is similar to the techniques used for balloon entrapment that I just described. So this is a case of a multivessel CTO person turned out for surgery with low LVF. There is an RCA CTO that is attempted first. A filler XTA reaches the distal landing zone into the true lumen, but the microcatheter turnpike LP cannot follow. Operator performs granuloplasty, so bursting a balloon at the proximal cap to try to soften it. Does not work, changes microcatheter. There is also a guide catheter extension, does not work. And then a new turnpike LP is advanced, but its tip breaks off and remains on the wire. So another balloon is advanced to try to release that area there, but to no avail. So what the operator does is to advance a second wire over a supercross microcatheter, rewires the occlusion with a rotowire flop. You see the supercross here is just at the side of where the turnpike LP tip is located, and perform rotational atherectomy. Be very attentive here. You will see that a rotational atherectomy will fragment and pulverize the tip of the microcatheter, as you can see here in two fragments. One of them will just embolize distally at the coaxial. I'll let you see it again. Big fragment get split in two smaller pieces. The one embolizes distally. Actually, you can see the embolized fragment is here at the crux. but this is conveniently excluded with a stent, and this is the final result. What about atherectomy devices? Causes of burr entrapment include tortuosity, poor technique if we advance too quickly, too early before achieving adequate lesion magnification. This is especially common with the small atherectomy burr of 1.25. Of course, if we do atherectomy through stent, the metal interaction can be very tricky. And if we do atherectomy over a kinked atherectomy wire, the burr can fracture, of course, after entrapment. If we try to pull it out too aggressively, can fracture from the rotoblade or CSI shaft, or in case of tortuosity over excessive pull after insufficient plaque modification. For burr entrapment, first we should try to dynaglide or glide assist, depending on the device, while pulling the burr out. Then we should be mindful that the distal part of the atherectomy wire has a 0.014 a tip that is larger than the actual inner lumen of the atherectomy component of the device. So if we pull it out, we will hook up this the burr. Then over a second wire, we can advance a balloon to try to free the burr with balloon angioplasty. This can be done either in the true lumen, or if there is a CTO or a 95% or more lesion, sometimes we have to cross subintimally and release the burr by doing balloon dilatation in subintimal space. Last options are cutting the device shaft and advance a guide catheter extension over the broken shaft to exert localized traction with or without the help of a snare or surgical removal. In case of burr fracture, we should try to snare it. If it's in an adequate site, we can even try to bury it with the stent. It's been described. But if the burr fractures because it jumps outside the coronary artery and it perforates, we should apply the perforation algorithm with the pericardiocentesis, cover stent, fluids, or pressure. And surgery can be required in case of devastating perforation, or if the burr cannot be retrieved with other techniques and the patient is unstable. So this is a case of a little old lady, 88-year-old, tortuous and calcified RCA. We do atherectomy, 4 passages with orbital atherectomy, but then the fellow, when pulling back the device, does not feel there is resistance. And so what happens is that the burr gets the crown gets fractured here. The vessel is still patent. So what we do, you can see here clearly the fracture. Since the crown has an inner diameter of 0.012 inches and the tip of the viper wire is 0.014 inches, we can just pull back the wire, trying to hook this part of the crown, and then it will come back, but it will just get stuck here at the guide catheter because of non-coaxial alignment. We try to pull harder, but then we feel the wire elongating, about to break, and the crown is still stuck. So we advance a guide catheter extension, make it more coaxial, and then pull everything out as a unit. And finish the case being more conservative with this lesion that could not even be crossed by the atherectomy earlier. So this is how it looks. So summarizing, any interventional device can get entrapped or lost in the coronaries. The management approaches are basically 3 types. Extraction by pulling with or without using a snare, a guide catheter extension of trying balloon angioplasty to free the entrapped device. We can also abandon the device. If it's in a distal vessel, a small vessel, we can just leave it there, or in case excluded or buried with a stent, or in extreme cases, we should require surgery. Importantly, we should have from the very beginning a plan A, B, and C, because some maneuvers that we do, for example, that pulling energically a trapped burr, can actually worsen the situation, cause a second complication, like a perforation. So we should also be able to foresee that occurrence and deal with that. And especially in this particular area, I would recommend to having our cath labs and learn how to use snares, both small micro snares and big ones. Thank you very much for your attention.
Thank you very much. Unfortunately, this is an early morning in the United States, so he's not with us on live to take the question and asking him and taking the answer from him. So we'll ask the panelists any comment. طبعا before, I would like to welcome Dr. Faras Al-Alani from interventional cardiologist from Dubai, American Dubai Hospital, who will be with us as a panelist and a speaker. So let me ask this, common things we have the one he of course he did an overview of wire catheters and the rotablator wire, but usually the wire in the calcified region when it gets stuck, what is the tip and tricks? And also when we do bifurcation and the jailed wire, when we pulled it out, especially when we do the pot, what is the tip and tricks to pull it out safely without broken the wire? So Dr. Omar, any comment on these two? If these have heavy calcified, the wire got stuck, what are the tips and technique to pull up the wire safely?
So I think if your wire is stuck in the calcium cassette plug, we could do two things. We can send microcatheter over that wire to pull with helpless microcatheter, or secondly, maybe better, you can try to modify the calcium and that calcium with the stiff wire like Concast Pro. Then you can go parallel that wire to puncture the plug, the calcified plug, to release the first wire. And also, if you have trapped burr in the calcium, we do the same. We just try to, penetrate that calcium with the stiff wire to release burr, which is very helpful if you have trapped burr. And secondly, when you try to remove your wire, first of all, you shouldn't. If you use that wire several times in the case, I don't recommend to use it. It's a tight wire. Don't jail it. We should jail fresh wire. This is number one. And secondly, when we try to pull it back, it's easy. But what we do, we always disengage from the ostium of the coronary with the guiding, and we send a balloon over the main vessel to have anchor, not to lose guiding. Then we pull wire slowly. Most of the time it comes. Even you have sometimes need stronger pulling, but most of the time it comes back. If not, then you should definitely send something over the wire, balloon or microcatheter, and you should pull. Last thing, that you can dilate over that the gel wire to release your wire. Yes, you can do it 1.0 balloon. You can send it over the wire, dilate and send, dilate and send, and you can remove that gel wire. And another important tip, I think, never for the side branch. If you jail the side branch wire, that wire shouldn't be looped. Otherwise, when you pull it back, that loop easily trapped by the main body stand. This is could happen.
And even if you use a stiff wire in the side branch, when it is jailed, it's very tough. When you pull it, you may break the wire during when you pull the wire jailed. When it is a stiff wire, so you use the hydrophobic wire, soft wire, rather than stiff wire.
Right.
Dr. Faras Al-Alani, can you comment about any tips and tricks in your experience of the trapped wire in the heavy calcified and in the side branch under the stent when it is jailed, how you pull, and what's the tips and tricks in that?
Thank you, Dr. Musa, and thanks again to the organizing committee for inviting me. It's an honor to be here on my first time. I think the point that were pointed out by Dr. Omar and the speaker were very elegantly outlined in terms of what needs to be done, but some basic principles needs to be kept in mind. Now, we always kind of go back and forth between hydrophilic and hydrophobic wires when you're dealing with branch vessels, and if the strategy is a primary or a single stent with a modified or a bifurcation stent as a bailout. If you go in with one strategy of a single stent and you are gonna put a side branch wire, you got to keep in mind both types of wires will have their own problems. So a hydrophilic wire may be easy to pull out and recross because they're hydrophilic, but if you end up going with a bailout double stenting as a strategy, then the hydrophilic wire may end up being your enemy, because then you can strip the hydrophilic wire much quicker. I tend to stick with somewhere in the middle of the road, like a BMW or a run-through, which has some hydrophilic component to it, but they're really not considered hydrophilic. And then keeping in mind that if there is an old stent, if there is a calcified lesion, pull the wire. We tend to keep the wire in if we're not going to stent, to say, is the diagonal and stent across the diagonal because we feel comfortable that the wire is going to come out. Well, 90% of the time that's the case. But if you have an old stent, if you have a calcified lesion, you also need to think about pulling the wire, because quite often that calcification behind the stent, or even if you post-dilate, that could be a nidus for trapping the wire. So lean towards the safety of pulling the wire out, and then if you have to recross it, recross. And I think those are the few components I would add.
Dr. Fawaz, please, if you want to have any comments. And
I think it's already, in the presentation was a great level that mentioned all the tips and tricks in handling problem with the wires and balloons and stent and rotor burr. I think it's what we're trying to say is, especially in the broken wires and balloons and stent, if you want to go to the complex cases, you have to understand that this is the complication that you may face, and you have to be ready for it. But the most important thing is you have to prevent it from happening. As Dr. Omar say, we have to believe in what's called a tired wire and tired balloon. Don't exhaust them. If you use your wire more time and you find that tip is not working nicely, change it. If the balloon have used multiple times and you're afraid that it will inflate and not deflated, just change it. So I think the most important lesson for me in this chapter of the complication is try to prevent it by understanding your coronaries, and try to prevent it from happening before you fix it.
Dr. Ahmed Qasim, you want to comment anything before I go to the next speaker?
Yes, I think most importantly, when we make complex anatomy and jailing wire inside branch, my preference to use regular wire, workhorse wire, because the BMW wire is safely to be pulled out back in this heavily calcified lesion. We have case of peeling of the cyan blue wire, peeling after we jailing this wire because it is hydrophilic wire. So I think we should avoid hydrophilic wires and stiff wires in jailing by the stent. This is first point. Second point, I think when to avoid the stent loss in this complication, which is very disastrous, very importantly to look for the guide catheter. Guide catheter should, when many times we're facing calcification, we cannot advance the stent, so we obligated to pull back the stent again. So very importantly to look to the guide catheter, is it aligned or not? Because this is the most critical time for slippage of the stent from the balloon. And if the stent slipped in the proximal area and this stent is discrepancy with the proximal part of LAD or L6, I think we have two scenarios. Either the stent slipped over the wire or without wire. If the stent slipped over the wire, I have a very important technique I presented in EuroPCR, what I call balloon push technique. I inflated a very small balloon, 2 millimeters, over the proximal half only of the stent, not all the stent. Then I push the stent more distally to the pre-planned location. This when the wire is inside the stent. When the wire is not in the stent, or the stent is not on wire, I think the last resort to us is make a crushing of the stent. Crushing of the stent is a need for stent thrombosis later on. So much better to either deploy if it is inside over a stent, or snare it out.
Thank you. Dr. Wael, before further.
Good morning, everyone. I have a comment here, and it was like an observation we found in cases with a jailed wire technique using, I know BMW is one of the safest, but this observation we found is that the body of the BMW get the outer coat get stripped. and it was only recognized by OCT. You cannot see it under fluoro at all, and it's usually under the stand, and we don't know really it happened. We recognize 4 or 5 cases accidentally, and we don't know what is the long term of this. It shouldn't make any complications, but I just wanted to highlight this because for us it was really uncomfortable. We didn't know what to do with these cases. They will be on dual antiplatelets for a longer time. We kept them like for 30 months. But this is an observation I wanted to share with you guys.
I fully agree with you. It happens to me with BMW, but it happens to me recently. Recently I saw it. You know, I used to use BMW long years, but last 1 or 2 years I see this problem.
It was a universal too, mostly, and you cannot recognize it unless you do an OCT. Really, and we got the wire out and we check it after. Only under microscope you can see this, but by bare eyes you cannot recognize anything. But it is there in OCT. It is under the stent. So.
Thank you. Now we move to the first case presentation by Dr. Hussein Hishmet, interventional cardiologist from Fujairah Hospital in Fujairah. Unfortunately, he's unable to come physically, so we will have his session by webinar and virtual. Dr. Hishmet, welcome, please.
Thank you, Dr. Musa, and thanks for inviting me for this elegant meeting. I always learn from complication sessions more than what I learned in years. So this will be a continuation of the theme of this session, which is how to handle broken or embolized gear. And I'll be presenting 2 cases. The first one where the decision was easy, and the second case where the decision was rather tricky. So the first one was actually a patient from another hospital. That was 1 year ago, 1.5 years ago during the COVID heat. The patient had severe COVID pneumonia, was mechanically ventilated, had severe sepsis. He was monitored invasively, and he required a central line in that hospital for the infusion of vasopressors. You see these ugly images that we hope we don't see again. And this is the X-ray that was done after the central line was inserted. And you can appreciate here there is a long wire that's spanning all the way from the superior vena cava to the inferior vena cava. And probably the operator missed it. And it's a surprise to me, how did that happen? Anyhow, the central line was working. They discovered that there's a wire inside the patient. So he was referred for retrieval of this lost wire. And the patient came to us. He was mechanically ventilated and on a large dose of norepinephrine. And this is the image by fluoroscopy. We had a femoral vein access. And you can see here the image on the left side. You can see the central line is very decently located in the junction of superior vena cava right atrium. But you see the wire here, there's a straight end, and the J end is down in the femoral vein. So the wire was long enough to span the distance from superior vena cava down to the iliac vein. So what we did, we got the triple loop end snare, and we tried to catch it first from below, from the femoral vein aspect. So it was a 20mm snare, but probably because his vein was big and for some reason, maybe it was in a branch, I don't know, we were unable to catch any part of the wire. The distal end, the J wire, was completely out of reach. Even it seemed very close. And we tried to manipulate the snare, but it didn't work. So based on the suggestion of one of my dear technicians, he said, let's try to go to the upper straight end. And we did that again, and we did it through a multi-purpose catheter. So we tried to fish for the tip of the wire, and we were able to grasp it. And we made sure that it was tight, and then we continued dragging it all the way down from the superior vena cava, bringing it down across the heart. Nothing injured the right atrium. And you see the wire was too long, and then we were able to get it from the femoral vein. took the whole system out, and this is how it looked like. You can see the lost wire is regained and the ensnare was there. So that was rather an easy decision to make. The wire was long, accessible from either below or from above. The second case is a bit tricky, and I saw it once and I don't think I would see it again. So this was apparently a straightforward procedure. A 62-year-old lady, hypertension, diabetic, chronic atrial fibrillation. She presented with typical anginal pain, significant troponin elevation, and dynamic ECG changes, and a preserved ejection fraction. And you see here the vessels are a bit big for a middle-aged elderly lady. She has some aortic incompetence, and you can see here there is an eccentric ulcerated lesion in the proximal LAD. But what catches the attention here is the big size of the vessels. This was back in September 2019, before the pandemic. And at that time, we were familiar using the self-opposing stent, the exposition stent. And based on our assumed diameters, we pre-dilated, of course, heavily with a 3.0 25 NC balloon, because these stents need proper lesion preparation. And then we went with our self-opposing stent, distally 3.5, this is where you size, approximately 4.5, and the length is 27 millimeters. And we positioned the stent to cover the lesion and not to project into the left main. And we inflated the balloon up to the recommended inflation pressure of the stent of the balloon. And this is how the stent works. The stent is mounted on a semi-compliant balloon, but it had to be restrained because it tends to self-expand. And when we inflate the balloon, we split the sheath and we release the stent, but the sheath is still attached to the balloon, so we can go out with the balloon and the sheath, and the stent remains in place. And this is that we used to use this to deploy this stent in large vessels and in left mains, because it tends to conform with two different diameters, 3.5 and 4.5. And then we deflated the balloon, and here things start to get messy. The balloon doesn't come out, and whenever we try to pull the balloon forcibly, then the guiding catheter tended to jump in. We repeated the inflation and deflation cycle several times. Even we went to higher pressures, 16, to make sure that the sheath would be detached from the stent. And we tried to pull out again, but again we encountered the same problem again. So what we tried to think that instead of forcibly pulling things out, then let's try to take the balloon itself also out with the delivery system. And you see what happened here. The stent migrated significantly into the aorta, which was something out of the blue. And that was the situation here. We had a wire in the coronary, and the stent, you can see the radio-opaque marks are well into the aorta, but also part of the stent, I mean the distal part of the stent, was still inside the left main and also engaging the proximal LAD. And this is the point where we had to think, what should we do? And we had two ways to go based on the Manos-Brilakis algorithm. Should we try to snare the stent and retrieve it, the part that's floating in the aorta? And you can see here the stent was well opposed to the left main and expanded in the left main, and also expanded in the proximal LAD. And in order to snare that, we probably had to go with a ping pong. The procedure was a radial procedure, right radial, so we had a ping pong and insert a guiding catheter and a snare and take the stent on the snare. But we were worried that the expanded stent was too big, and I was not sure that we would be able to take it from the femoral artery. And we're also worried that dragging it along the way in the aorta, it can fly anywhere that was unplanned. So we chose the other way, that we would leave the stent and anchor it with another overlapping stent in the proximal LAD. We tried to secure our position with the guide liner, but things only got worse. And we had nothing now inside the coronary. So we had to recross from the stent floating into the aorta again. But the only way to do that was not through the inlet of the stent, was through the struts of the stent. We went in with a wire, we secured access across the coronary, and we crossed the lesion. But in order to execute our plan and to overlap a stent in the LAD lesion and anchor the stent here, we had to dilate the cells, the struts of the exposition stent. We did that with a 3mm balloon through the guideliner. And you can see the balloon was able to be delivered inside the stent into the lesion of the LAD. And then we inch-warmed a guideliner. So the guideliner here, it's a bit funny, but the stent through the cells in the middle of the stent, there's a guideliner well into the lesion. And we were able to deliver a stent. Now it's a balloon expandable traditional stent, an Ultimaster. And it covered the lesion, and we also anchored the stent. So the aim here was to treat the lesion and to anchor the stent so it remains in place, and the part which is in the aorta is exposed to very high flow, so it's unlikely to thrombose, and as long as the stent is anchored with another overlapping stent, so it will remain in place. And this is the final result. After we optimized the overlap zone, it was an Ultimaster 4.0. And so you see here the left main is patent, the stent is opposed, and the lesion has been well treated. We confirmed that with a panoramic display of the coronaries. Apart from the stent that was too much protruding into the aorta, everything seemed okay. And the patient went asymptomatic. Her ejection fraction was normal. She was discharged 48 hours. Maybe her atrial fibrillation was an advantage, so we were aggressive in anticoagulating her on a NOAC and Plavix for a year, then continued only on NOAC. The patient remained asymptomatic all through 2019, 20, and 21, until she came back, and it was just a couple of weeks ago, this month. And she came with a different complaint. She came with fever, acute respiratory distress. The X-ray showed a classic picture of lobar pneumonia, but it was severe. She was in sepsis. She had to be intubated and mechanically ventilated. But on presentation, she also had some ECG changes that we didn't understand. Was it a real event, or it's just the consequence of shock? But because of troponin elevation, ECG changes, and the event that we had 2.5 years earlier, so we said, let's go for angiography. And this is the angiography of the right coronary. It was okay. And looking here, maybe the image is not clear enough, but the staining of the left coronary sinus, there's nothing protruding now into the left main. And we had to be very cautious when cannulating the coronary. But for our surprise here, you see that there's nothing protruding anymore into the aorta. The left main is fine, the LAD is fine, there's no significant lesions, maybe just some tissue neointimal hyperplasia, but there's nothing protruding back into the aorta. We went selectively, and we saw only one radio-opaque marker of the exposition stent, which was the distal marker. The LAD was fine, no significant lesions, and there was no significant coronary problem. And we estimated that probably part of the stent silently embolized. And to make things, this is my own understanding of what happened. The exposition stent has a special design that the connectors of the struts can be easily disconnected. It can be split and open. And this is an advantage of this stent when you're doing a bifurcation, that across the carina, the stent can be partially dismantled. So this is my schematic of what happened. This is the aorta and the left main, the LAD and the circumflex. And this is the exposition stent here, overlapping with the Ultimaster stent. And we made sure that the overlap goes just be distal to the circumflex ostium. And because we had to create a small hole here, or a big hole actually, in the stent with the balloon and the guide liner to deliver our equipment, to deliver the Ultimaster. And this part is exposed to the strong forces of the aortic flow. So probably what happened is this hole under continued pulse pressure, it probably disengaged and it embolized silently into a place that didn't cause any symptoms for the best patient's luck and for our best luck also. So these are two cases where one, the decision was easy, you had to take everything out. The other one, we preferred to leave it inside, and of course it's open for discussion. Thank you so much.
Thank you very much, Dr. Hussein Hishmet, for very nice cases too. I think the most exciting one is the second case. So I will just see the opinion of the panelists on if they want to comment on the first or particularly on the second, since the exposition stent now no more they are manufactured.
Exactly.
Yeah. So. So what is your explanation of undeflatable balloon when you inflate it? You know, exposition, I use it in the past before they stop. It's good for ectatic vessels because it's expand in the 3, 5, 4, 5, go up to 6 and above 6 even, well expanded. The only technique is that the balloon, the stent is wrapped by a balloon, so you have to peel it. You peel it from down, and then it will expand. The peeling is a little bit tricky. You have to be well known about this peeling. But of the balloon, how do you explain that the undeflated balloon when you deliver the stent? Your explanation. Why?
The balloon was deflating.
Yeah.
The balloon was deflating, but the system doesn't come out.
Come out. Okay.
I think this was a manufacturing issue.
Okay.
We went to the recommended pressure, and we went even higher when we found that the system is not coming out. So the problem here is that the sheath was sticking the stent to the balloon. So we didn't know how to take it out.
Well, you know,
and leaving the stent inside.
Yeah. The stent they stopped manufacturing, but there was the trick that they usually when we used it, they said go to the very high pressure to expand it, but actually we should go to the nominal pressure, so allow time to peel off the sheath and then do post dilatation with high pressure to avoid this complication. Yeah. Any comment, Dr. Faraz Al-Alani or Dr. Umar Fawaz, any comments on the second case?
Another thing could be done rather than pulling the balloon, because there's a risk for pulling the stent as well. Yes. We can cut the balloon and then we can send a extension guide, and then we can, insert extension wire over the balloon, because I think there is a trap between balloon and stent. So rather than pulling the balloon, we can resheath the balloon. We can insert a extension guiding to have balloon in the extension guide. I think that could be done. I don't know if it works. I don't know. Yeah. The other thing you could say you could do snaring maybe. It was very easy to snare in that stent because there's a big overlap part. And why it's broken? I think maybe you did more than half of the disconnection at the ostium already because of the ballooning. So it wasn't that difficult, maybe broken. Did you do IVUS, by the way, to see the stent strut IVUS?
No, not really, because the patient was in sepsis. Her systolic blood pressure was 90. Yes. So we were just happy that the coronaries were fine, and we went out.
Any comment, Dr. Ahmed? تفضل. Then I give to Dr. عمرو الحديدي. تفضل.
Congratulations, Dr. Hussein. I think I agree with you that you don't snare this stent. Yani once the stent is migrated to abnormal place and it is already inflated and deployed, much better to optimize this stent in this abnormal place and use a second stent. This is number one. Number two, as regard to the first case, actually, I think I don't understand why this very long wire yani, is lost in this. Yani, can you explain why this very long is left in this patient?
I don't know.
Very long wire.
It was another hospital, and I didn't have. There was nothing detailed in the records. When I looked at the report of inserting the central line, they said everything went fine. So it was hard to know the truth. The patient came by an ambulance, ventilated from the other hospital just to take the wire out.
Turkey, بس دكتور عمرو الحديدي wants to ask you, Dr. Hussein, and then I will leave for Dr. Fawaz. تفضل دكتور عمرو.
Thank you, Hussein, for this great cases. Definitely his chance to go after this bad CT of COVID pneumonia and then all these complications about all these years, this is a very fantastic result. Definitely the point is sometimes when you're pulling back the stent and come out easily, and I think snare is a good idea to try to get it because I think it needs post-dilatation. The stent is always need post-stent deployment sometimes in some cases. If it can easily, you can try. If you can easily come back, I think you choose the second choice that you need to more dilatation after putting this malposition stent. This is a point. Another point is when you are dilating, as you mentioned, this is a very bad connection between the struts. So if you do the dilatation and then you can fix, and you have now a wire, and if you try to dilate more the left main, so you can have easily, if you snare this part of the stent, you try, just to try to get it out. I think it can easily come.
Dr. Fawaz, you have blood.
I think the part of the snares have been mentioned. Thank you very much, Dr. Hishmat. It's a great cases. For the first one, I think it's if you cannot get it snare from the femoral axis, I guess the end of the wire is a bit stiff. So bending it in the SPC and right atrium, maybe it's not safe 100%. Personally, if I cannot get it from the femoral, I'll just go to IJ and try to pull it up, because I think it's bending it. It's made damage the RA. For the second case, I think you did a great job. Maybe personally, I will try to snare it as much as I can, even if I end up having a big bore femoral axis.
Yeah.
Dr. Khalid, last one before we move. تفضل Dr. Khalid.
Dr. Hussein, thanks for the cases. Okay. Yeah, thanks for the cases, Dr. Hussein. Good questions regarding the first case. Pearls of wisdom. If probably because of I'm not doing any justifying what happened. Probably during the COVID, they are covered. They were when they inserted, probably they forget the wire inside. Pearls of wisdom is when the wire, especially for the sheath or central line, just if anybody forgets it, like inside, just pull the catheter and the guide wire will come with the catheter itself. Okay. For the second case, did you search for the lost part of the stent? Like, did you go for the carotids or the femoral? Because the most important thing is looking to, the patient was saved, and all of us we know, because of the NOAC. That's why there was no some sort of any, thrombotic embolization. So the most common place usually, what's written in the textbooks, is the right femoral, where you're gonna find whatever lost in the aorta. This is where the common place to find lost instruments, I would say. The other thing, did you search in the carotids? Did you search like anywhere else, like, scanning the patient? That's it.
Yes. Trying to snare the wire from the jugular was not an easy job, because he already had a central line on the right side, and that was where the norepinephrine and the vasopressors were running. And he was intubated and mechanically ventilated. So trying to cannulate or puncturing the jugular or the subclavian when bilaterally when he was intubated and under positive pressure, to me seemed a bit hazardous. That's answering Dr. Fawaz's question. As for for the second question, of course, we give credit for everyone. I didn't blame anyone for keeping the wire inside. It happened twice, but I think they had an issue there in the other hospital and they fixed it.
Just a quick comment. Dr. Hussein, thank you for the case. This is Firas Al-Ani. I guess, I mean, it's always good to be lucky than good, and it's good to be both. Being an educational conference, I think it's important to point out to young physicians who are learning from this is the basics. I mean, you had a stent, and the stent was left in the left main, half of it is hanging. To me, gambling on a high flow system and to bail a patient out from a fatal complication of left main stent thrombosis is always a tough decision, and I applaud you for making that decision. But as an educational point, I think we could always consider this would have been a simple open heart surgery and removing the stent. I know it sounds too big, but thinking of the alternative, which could have been a fatal complication, to me is very important. So I just want to point that out. Always think open heart surgery, removal, you come back and you tell the patient, look, this is what happened. I'm sorry, things happened, but this is how we're going to handle it. Thank you.
Last comment from you, Dr. Hussein Heshmet, before we move, please.
Yes, thank you, Dr. Firas. I really appreciate your comment. But the issue here, what was the threat that we were afraid of? Were we worried about stent thrombosis or we worried about embolization? I think we were worried more about embolization because the stent was well expanded in a part where there was no specific large plaque burden. So the risk of stent thrombosis to me was not there for two reasons. Number one, because of the high flow of the aorta. Number two, because the stent, as Dr. Musa said, it reaches easily 5 or 6 millimeters. And you saw that it was well expanded into the left main. So the hazard of stent thrombosis was not there. The hazard of embolization, I think it always remained, but we try to mitigate it as much as we can by anchoring the distal stent in the proximal LAD with another balloon expandable stent. But of course, all the options could be valid.
Thank you very much, Dr. Hussein Heshmet, for very nice cases and the cases and management. You did very well job. Thank you very much, and we'll see you, inshallah, in the future. Thank you, Dr. Hussein. Now I would like to introduce our last case presenter, Dr. Firas Al-Ani, consultant interventionist in the American Hospital in Dubai, to give us his case presentation upon the wire went too far. Dr. Firas.
Thank you very much. Again, I apologize. This may have been a mixed presentation between the first session and the second session, so just bear with me. I think we learned from all kinds of complications. This is quickly a 65-year-old female with history of exertional shortness of breath for 3 weeks. She was then admitted after 3 weeks of having these symptoms with a chest pain and ruled in for non-STEMI. Her past medical history was significant for we'll then know that are the player factors: older female, older, and renal insufficiency and diabetes. These are her vital signs. Examination unremarkable. She had a murmur for a mitral regurg. I'm going to go quickly through the case. We did do an echo. The echo showed normal LV systolic function. There was moderate MR, and she had severe pulmonary hypertension, and then the ECG did show some ST segment depression in the inferior leads. Angiography was done, showed multivessel disease. She had a very diffuse proximate LAD stenosis and a major diagonal that also had stenosis. Her circum left main and RCA looked patent. The right PDA looked patent, but she did have a subtotal occlusion of the right PLB, which was giving collaterals to the LAD and the left system as well. This is pictures of her. You can see in here I don't have a pointer here, but you can see down where the PLB is subtotally occluded. And this is a large PLB, by the way. This actually goes all the way down to the lateral wall. And then you can see the left system has a diagonal and the, thank you, has a diagonal disease, very large diagonal bifurcating superior inferior branch and the very long proximate LAD. So we referred the patient to the heart team. The discussion was to proceed with the multivessel stage PCI. She was turned down by the surgical team because of severe pulmonary hypertension and stage 5 chronic kidney disease. It's, in between the diagnostic and the PCI plan, patient did talk to her nephrologist, and they elected to proceed with dialysis because she was really, her GFR was 8 before the PCI. So the plan was to bring her in for do the LAD. The LAD was, and the diagonal was straightforward case. Again, I say straightforward until we see what happened. We got access to the right common femoral, XP35 guide, wired both vessels, ballooned the LAD, ballooned the diag, stented the LAD with a 40 millimeter stent, again stented the diag with a 225 stent, and then post-dilated the LAD with a 1-to-1 size for the stent and the diagonal as well. Vascular closure, angioseel, everybody went home. Nothing big deal about the case. I don't know. Can I click on the play button here? Or can... Thank you. So, next slide, please. And if you can play that. So this is the after PCI. You can see the 225 stent in the diagonal, and then the 30, or I'm sorry, 25 post-dilated into the LAD. So the patient doesn't have any issues here. We get her back to the floor. Next slide. And 4 hours later, she became short of breath, diaphoretic, chest pain, tachycardic, hypotensive, and I'll go back. And then we did an ECG. First, of course, the first thing comes to mind is stent thrombosis, acute. There was no signs of ST elevation in the anterior leads. And then we did an echo. It took us a while to get the echo machine, but I just took the ultrasound machine on the ICU, and we saw a very large effusion. At this point, she did respond nicely to some pressors, and the question was to tap her at the bedside or take her down to the cath lab, and that's an open discussion we can have. I felt that with a little bit of dobutamine, and I'm sorry, dopamine at that point, her systolic was 80, she was mentating very well. More controlled setting in the cath lab, we took her down to do the tap. Can you play the film, please? Can you go back one slide, please? And can you play the film? Thank you. So you can see here now we knew what's going to happen is that there's a perforation, and this is a large perforation by virtue of having pericardial tamponade. It was difficult early on to decide which branch was the perforation coming from, and clearly it's from the diag, but it was a superior or inferior branch. The wire slipped through the stents of the struts and the diagonal into the diagonal superior branch. Next slide. And at this point, I went in and put the pigtail drain, and the patient's hemodynamically became stable. Next slide. And we kept kind of draining, but the blood didn't stop. We keep putting back blood, and then finally we got into the better imaging, but at this point everything was in a controlled fashion. Next slide. Now here you can see, in the previous slide, you can see that the wire was in the superior branch of the diagonal, and we did a couple of balloon inflations in that branch, yet the bleeding didn't stop. At some point I actually had the balloon up for 3, 4, 5 minutes, and I kept pulling bloods from the pericardial space. And then on further imaging, we realized that there may be a second, the source of the bleeding was from the second branch. I repositioned the wire and went in with another balloon, and still prolonged inflation didn't really stop the bleeding. Next slide. And here you can see almost the tail of the injection towards the end of the injection. That kind of volcano eruption has like a little bit of a wedge shape that tracks all the way back to that inferior branch. Question here is, this is now a 2.0 or even a 2.25. I don't think it's even a 2.25 vessel. And we had only 2 stents of covered stents on the shelf. One was a 3.5, which we're not going to put here, and the other one was a 2.5. And the length of that stent was a 24 millimeter stent. So we decided to proceed with the covered stent. And then finally we got a final result here. The stent did, I will say, got stuck somewhere here in the left main and had to take off right at the knuckle of the diagonal, but with the grace of God, it went through nicely. So really the points I wanted to make, clearly, elegantly pointed out again on the previous session. This was a PT Graphics wire in the diagonal. PT Graphics wire is a very prominent hydrophilic wire. It gets you through tight lesions, but you gotta be aware that they are high risk for perf. Your lab should be equipped with all kinds of cover stents, and I will say all sizes. And trust me, that's an investment that's well spent. The issue here of antiplatelets reversing or heparin reversing, I think the discussion is clearly here. You know, when you have fresh stents, you got to go and take care of it, and the last thing you want to do is reverse, because the flip side of the complication is full stent thrombosis. It's important to be calm. I think these are important points that were very elegantly pointed out in previous sessions. Keep in mind that a perf of a wire is a very small hole, and I think just getting your pericardial centesis kit and getting the patient stabilized, and then you have all the time you need to think, discuss, pull other colleagues, and don't rush any decisions, and really be prepared to coil your branches and sacrifice a branch if needed. Thank you very much.
Thank you very much, Dr. Faraz, for this nice case and the management. So I will leave to the panelists if they have any comment on the case. Dr. Amr, you want to start, please?
Thank you, Firas, for this great case. Definitely, you always keep the patient after intervention in a close monitoring, because sometimes it cannot never happen in this case. This is a very good, important point. Some patients were discharged after 3 hours or 2 hours after PCI, especially if it was in radial. So the best is to wait and see in patients, especially if you are using a lot of maneuvers, and especially in this case. The point is, I think also if you go not go across with a covered stent, you can use coil. It's more easier and more go distal in the branch directly to see the best to close this perforation. Sometimes the covered stent is bulky, especially if you have a stent at near the edge of this bifurcation, so maybe difficult to cross. And the problem is also if you have a crush stent, so maybe more difficult too, so you need to use a coil is much better. Thank you.
So Fawaz, tafadhal, if you want to come.
So, thank you very much. It's a great presentation. I couldn't see where you end up putting your cover stent at the end, but if it's a perforation of a branch, maybe not going after that smaller branch and just put the cover stent bigger size in the main diagonal to jail that branch completely, and that will stop the perforation. You end up having a bigger cover stent that will have less risk of stent thrombosis, and even the amount of ischemia will happen there, it's minimum.
Yeah, it was very unclear at the beginning of the pictures, Dr. Fawaz, but we then realized those superior and inferior branches were not equal in size. the wire slipped in the superior branch, and after multiple balloon inflations, we recognized that the bleeding is not from that superior branch, it was from the inferior branch. So I then rewired it, pulled it back, and put it back in the inferior branch, and that was almost double size, if not double size the superior branch. So the issue here would have been to put the covered stent in the main diagonal into the superior branch and jail the inferior branch, would have been then putting that covered stent in a 1.0 vessel distally. And what I did is I positioned the covered stent, which was long enough, at the site, and I was able to really find out that tail of and cover the site of the perforation.
Thank you, Dr. Faras. Actually, the wire tip perforation, this is a typical example of late presentation after 4 hours presentation of tamponade, and most probably it is passed unnoticed in the cast lab, tip wire perforation. Most commonly occurs with hydrophilic wires or stiff wires. So I think it is very important to, in complex cases and using stiff wires, hydrophilic wires, to keep observation of this patient and follow up him after that. Second point, I'd like to ask about why don't think for coils for this branch rather than cover stent?
Sure. I think the coil is always an option, and I figured we could just, if I could close the perforation while keeping the patency of the vessel, to me is always a better situation than ending up with an infarcted distal territory. Look, I think at the end of the day, you got to get through the complications, but my thought was the covered stent will address the small perf, and we always have the plan B of putting a coil if the covered stent didn't.
Yeah, but thank you very much for presentation. But now we have, stent, covered stent in stent. So there we have, to me, maybe 20–30% of restenosis right here, big diagonal. So I would definitely go with coil, because of that. Now we have restenosis rate. It's easy to solve the problem, but.
Right. I think the argument is if you coil, you close the vessel. If you put a covered stent, there's a chance of restenosis, and then you close the vessel. I would bargain of potentially future closing the vessel with stent thrombosis versus closing the vessel and walking out. I think if you have both options at your hand and you have to choose A or B, I think a covered stent would be a better option because you walk away with a patent vessel. With the price of that covered stent may thrombose down the road, or it may not.
No, I'm talking about the coil of the side branch of the diagonal.
Right, but that was a pretty...
So cross the stent with the macro catheter and to put coil in that branch, so you never touch the main diagonal then.
True, yeah, and that's where the covered stent went into the sub-branch of the diagonal. There was no overlap between the diagonal branch stent, which is the main stent, and then the other stent. But I think...
Excuse me, you put covered stent in the major diagonal?
No, the covered stent was in the sub-branch of the diagonal, which is the site of the perforation.
Oh, okay. Yeah. So you insert the covered stent into the ruptured part?
Correct. At the perforation.
Sorry, apologize.
Right at the...
I misunderstood.
Sorry.
Sorry.
That's exactly. I think it's in this situation, covered stent is better, even if the risk of restenosis in the future or stent thrombosis is there. But at least the risk is not 100%. While coiling is 100% risk of blocking the artery completely. So if he's planned already to go to the sub-branch of the diagonal, the cover stent, and you manage to put it there, excellent job.
But it's very small. Okay.
Thank you.
Yeah, thank you for this. But the point is, this is a very, very small, and this is a covered stent. The sizes were very, very small. So it's a very, very high risk for occlusion. This is not the point because it's a very distal branch. But sometimes if you don't have coil in your cath lab, this is the point. I present cases with like this, and we use what's called a gel foam. Gel foam was used for the chemotherapist in the cath lab. They sometimes injected the arteries. So if you don't have, you can put it in a microcaster, you can push the gel foam, and you can do it like a part of this gel foam inside the micro and push it with the back of the wire in the microcatheter, and then you can close this perforation. This is a very easy procedure if you don't have coils in cath lab.
Okay, thank you very much. I would like to conclude the session 6, broken wire catheters. Thank you very much, Dr. Faras Al-Ani, for being with us. Thank you for our panelists, Dr. Amr Al-Hadid, Dr. Fawaz, and Dr. Umar, and Ahmed Qasim, and thanks for Hussein Hishmet, and from United States, Lorazino.